Hello, I'm Professor Adam Thompson, and in this lecture, we're going to talk about bleeding. Specifically, we're going to talk about the anatomy and physiology and how it relates to bleeding or the hemorrhaging patient. And then we're going to get into, the treatment and all of those kind of things, the assessment findings, all of that. So A before B except after C. What does that mean? Well, airway before breathing except after circulation. When it comes to the hemorrhaging patient, you're going to want to stop a massive hemorrhage before you assess airway and assess respirations and all of that. And when you get to C, if you're doing your skill sheet, so to speak, or your assessment, when you get to C, you're going to control major bleeding. So if you have a major bleeding patient, start with controlling that bleeding and then assess airway and breathing. The paradigm has shifted from focusing first on the airway to focusing on circulation when there is severe hemorrhage present or suspected. Bleeding is an extremely time-sensitive condition, and the goal in trauma care is to maintain perfusion. Given massive hemorrhage, the C of circulation takes priority over airway and breathing. All right, so airway management is not successful if there's an inadequate circulation to transport that oxygen, which perfuses the tissues of the body. Even seemingly inconsequential bleeding could be dangerous. So it may be initially a cause of symptoms as vague as general weakness, but then it can progress, of course, to hypovolemic shock. Understanding bleeding management requires understanding the anatomy and the physiology of the cardiovascular and the respiratory systems. When you're talking about the cardiovascular system, it keeps blood flowing between the lungs and of course, the peripheral tissues. Every tissue in the body that's made up of cells, all of those cells require oxygen. The right side of the heart pumps blood to the lungs to get that oxygen, and then the left side of the heart pumps that oxygenated blood to all of the tissues of the body. In the lungs, blood unloads gaseous waste products and picks up oxygen. So CO2 is, the waste product we're most familiar with aerobic metabolism. It's produced when you're trying to create ATP, which is, that energy that our body needs. It utilizes ATP. And then the process is reversed in peripheral tissues, and blood unloads oxygen and picks up that waste that then circulates back to the lungs, and then you exchange the waste product for, of course, the oxygen. So we talked about aerobic metabolism. That's what happens with normoxia, or when you have a normal amount of oxygen within your blood cells. But of course, if you don't, you still have a type of metabolism, what's called anaerobic, all right, without the oxygen or without the air. You still have metabolism. This is what happens in shock, okay, when you're in a hypoperfused state. And the byproduct of aerobic metabolism or normal metabolism is CO2, as we were talking about before, whereas the byproduct of anaerobic metabolism, such as when you're in a shocky state, is going to be lactate. So lactic acid is one of the markers of shock. If blood flow were to stop or slow, cells would not be able to eliminate waste. Oxygen delivery to the tissues would be disrupted. Cells switch to that anaerobic metabolism, or without air, without oxygen, right? Cells would begin to die within a few minutes of circulatory failure. And then to survive, the body compensates to maintain a systolic blood pressure and perfusion to the brain and the heart at the expense of other areas. So if you're familiar with compensation, you know that the heart will do things like, pick up its heart rate to try to maintain blood pressure. You have that peripheral shunting of blood with a mass vasoconstriction throughout the body to try to keep blood perfusing, to the vital organs. All of these things happen in these shock states. So the circulatory system requires 3 intact components to keep blood moving throughout the body. It requires the pump, right, as we know as the heart, the pipe, which is, all of your vasculature, and then the fluid, which is the blood that fills up that vasculature. Those 3 things, it really comes down to, it's as easy as that. Those 3 things are required, to keep blood moving throughout the body. And when it comes to the cardiac cycle, it's the repetitive pumping process. All right. And preload is the amount of blood that's returned to the heart, which is to then be pumped out. So preload is like, you're loading the gun, you're loading the heart with, a certain amount of blood. And then afterload is the pressure in the aorta. all right, the peripheral vascular resistance against which the left ventricle must pump blood. All right, so it's what's the resistance of the blood coming out of the heart is your afterload. So the more afterload you have, the harder it is going to be for the heart to get its contents out. All right, the higher the afterload, the harder for the ventricle to eject its blood. Higher afterload actually will reduce stroke volume because of that. So it's not necessarily a great thing to have an increased afterload, but that's what happens when you have a profound peripheral vasoconstriction. Speaking of that, let's talk about blood pressure. So blood pressure is, the dividing line between the stages of shock. Blood pressure equals cardiac output times peripheral vascular resistance. Sometimes you'll see it's called systemic vascular resistance, sort of the same thing. Peripheral vascular resistance is measured as a mean arterial pressure, or MAP. And MAP equals the diastolic pressure plus 1/3 the pulse pressure. You're going to want to remember that MAP because it's a commonly used vital sign in the critical care arena. The pulse pressure is calculated by subtracting diastolic blood pressure from the systolic blood pressure. It's much easier to equate a pulse pressure than it is a MAP. A MAP can be difficult for people, but luckily most modern monitors, especially pre-hospital monitors, will actually calculate the MAP for you from the automated blood pressure numbers. So you can actually see, a lot of times it's in parentheses or off to the side of the blood pressure, you'll see the MAP is actually calculated for you, and it's worth paying attention to because it is a critical vital sign, and it's actually more specific and sensitive to certain conditions than a systolic blood pressure, which is traditionally what a lower level and mid-level practitioners tend to pay attention to as a vital sign. Cardiac output is expressed in liters per minute, and cardiac output, as we know, equals stroke volume times the pulse rate. So stroke volume, the amount of blood pumped with each beat, times your pulse rate is your cardiac output. So your cardiac output is the amount of blood pumped in a minute. That's what cardiac output is. It's what influences your stroke volume, your pulse rate, or both also affects your cardiac output. So anything that's going to increase your heart rate could increase your cardiac output. If you were to drink a bunch of caffeine, like a coffee, and increase your heart rate, you're going to then increase your cardiac output as long as you're not decreasing your stroke volume. But if you think about, your dehydrated patient, so to speak, when their heart rate starts to go up, because we know that's a compensatory mechanism for hypovolemia, right? Our heart rate will start to come up. However, our stroke volume might be down because of the dehydration. And of course, once your heart rate goes up to a certain point, there's only so much stroke volume that's going to be in the heart, because if your heart's beating too fast, it's not going to have enough time to fill up with blood. So it's a consequence of an increased heart rate that you'll have a decreased stroke volume eventually. Increased venous return stretches ventricles and results in increased cardiac contractility. Remember the Frank-Starling mechanism or Starling law of the heart. If a muscle is stretched slightly before stimulated to contract, it contracts with greater force. And it's like a rubber band. The more you stretch it, the more force that comes out of that heart, right? Okay, so remember cardiac output, it's important. A normal heart continues to pump the same percentage of blood returned to the right atrium, and this is an ejection fraction, right? So your ejection fraction is the amount of blood that's pumped compared to the amount of blood returned to the right atrium. If more blood returns, the heart pumps harder. More blood is pumped with each contraction, but the ejection fraction actually remains unchanged. Maintains a normal cardiac function through the positions it changes, such as coughs, etc. That's how a normal heart functions. Connecting and expanding the two equations yields this equation. Blood pressure equals stroke volume, which includes preload and afterload, times heart rate, right? Because we know blood pressure equals cardiac output times peripheral vascular resistance, also known as your MAP. Then we know blood pressure equals stroke volume times heart rate times your MAP, right? You can kind of break it down different ways and find out where that blood pressure comes from. This formula explains shock and indicates where treatment needs to focus. So if you break down the blood pressure formula, you can kind of break down the different types of shock and see where we're having an effect on blood pressure. For instance, if you have, like we talked about before, a hypovolemic patient, whether they're bleeding or whether they're dehydrated, then you know that they have a problem with stroke volume. You can also break down that peripheral vascular resistance a little bit more. We know peripheral vascular resistance is made up of three things. One is the lumen of the blood vessel, whether it's constricted or dilated. Another is the viscosity of the blood. So if it's more like water or if it's more like tomato paste. And what can change viscosity of blood? A lot of things. A loss of plasma is one of those things. A polycythemia makes blood more viscous and can cause clotting. All right. And then your overall volume. So stroke volume, we know, is the amount of blood in the heart. Your overall volume in the body or in the vasculature can increase peripheral vascular resistance as well. So an effect on volume, such as hypovolemia, will have an effect on both stroke volume and peripheral vascular resistance. Think about distributive shock. Distributive shock is like septic shock or neurogenic shock or anaphylactic shock, where you may have profound vasodilation, right? You have enough volume, but your vasculature is bigger, right? So there's not enough volume in the vasculature to keep it, the pressure higher. So that increased size of vasculature will decrease peripheral vascular resistance, causing a decrease in blood pressure. And we know that all of these parts of the equation will actually be the compensatory mechanism for the other parts. And what do I mean by that? So if I decrease volume, I'm going to increase heart rate. I'm going to, cause vasoconstriction in my body. If you cause profound vasodilation, as we do with the distributive shock, then you might have an increase in heart rate. We know septic shock patients tend to have an increase in heart rate. Anaphylactic shock patients, same thing. All right. What's another type of shock? How about obstructive shock? Well, obstructive shock causes an obstruction of the blood flow. So you may see an increase in heart rate. You may see shunting of the blood. Of course, you're going to have increased respirations and all the other signs of shock. But when you're looking at this blood pressure calculation, you really can break down the type of shock you're dealing with and where your treatment needs to focus. All right, so blood and its components. Blood consists of plasma, all right? 55% of it is actually plasma, which is mostly water. It's formed elements or cells suspended in the plasma consist of RBCs, which are red blood cells. And that's about 45% of your blood volume, actually. And then your white blood cells, less than 1% of your blood volume. Those are your fighter cells. And then platelets, we know we need for clotting. That's less than 1% of your blood volume as well. And that's what our blood consists of. The purpose of the blood is to carry oxygen and nutrients to the tissues. It carries cellular waste products away from the tissues. And there are other functions of formed elements, of course. We know that those white blood cells fight infection, and we know platelets help control bleeding. Of course, there's electrolytes in the blood and all of the fun stuff. Plasma is that watery straw-colored fluid, and more than half of your total blood volume is what your plasma is. And 92% of your plasma is water. 8% is dissolved substances such as chemicals, minerals, nutrients, all that stuff, globulins, if you will. Platelets are small cells essential for clot formation. The coagulation process is a complex series of events also involving your clotting proteins in the plasma, your other proteins, and some calcium as well. Blood circulation and perfusion, your arteries carry blood away from the heart. Remember, arteries, all of them except for one are oxygenated, right? They carry oxygenated blood. The only one that's not oxygenated, of course, is your pulmonary artery, because all arteries carry blood away from the heart. So your pulmonary artery actually carries blood away from the heart to the lungs to get oxygen. So it is deoxygenated when it does that. And veins transport blood back to the heart. So all veins are deoxygenated except for one, if you can guess it. It is the pulmonary vein, because the pulmonary vein returns blood from the lungs to the heart. And of course, there's more than one pulmonary vein. I shouldn't say all but one, but it's easier to remember that way. Perfusion is the circulation of blood within an organ or tissue in adequate amounts to meet the cell's current needs. Autonomic nervous system adjusts blood flow to the body's needs. Remember, the autonomic nervous systems, it works automatically, right? And it's this constant balance between your sympathetic and your parasympathetic nervous system. That's what your autonomic nervous system is. And remember, that sympathetic nervous system is your fight, flight, or freeze mode, right? So whenever you're hit with a stressor, you go into your sympathetic response. The body's reaction to internal or external stress is your sympathetic response. Its actions include a faster and stronger heart contraction, a faster and deeper respiration, along with bronchodilation. You'll have shunting of blood to the vital areas, much like all those things you see with shock. It's kind of your sympathetic nervous system, same thing, right? So you're going to get blood to your core. You're going to slow or seize all of your digestive functions because it's not time to digest food and all of that stuff. It's time to dilate the pupils, let light in, allow for your heart to pump, get oxygenated blood to your vital organs, and fight or run. That's what the sympathetic nervous system is made for. It's your adrenaline. Whereas your parasympathetic nervous system, that's your rest or digest mode. That's when the body rests and repairs itself. It's the counterbalance of the sympathetic nervous system, right? Its actions include slowing the heart rate, slowing the breathing rate, and the increase in your digestive functions. Now, you may know that whenever you have to take a test or do something very stressful, you tend to start feeling your belly move, right? You're starting to feel all this stuff in your belly move. What is happening? Well, a lot of it is from that immediate shutdown of your digestive system, because what happens when you sit down to take a test or you sit down and do something stressful is your sympathetic nervous system kicks in, and now we're kicking up the heart rate, we're kicking up our breathing, we're dilating our pupils, we're letting more light in, we're ready to concentrate, all of that. And then your parasympathetic nervous system eventually will kick in. What happens is the stronger your sympathetic response, the stronger your parasympathetic response is typically after that, right? Homeostasis. It's time to balance that out. And then when your parasympathetic nervous system kicks back in, all right, now the digestive system is going to kick in. Now we're going to feel that lull. We're going to start getting tired. Our body's going to want to rest and repair and do all of that. So that's what your autonomic nervous system is doing. All right, so now let's talk about the vasomotor center in the medulla oblongata, which helps regulate blood pressure. If there's a drop in blood pressure detected, baroreceptors will send stimuli to the brain via cranial nerves 9 and 10, and this causes an increase in the sympathetic stimulation. If blood pressure rises, the opposite will actually occur. With the endocrine system, it also responds to your blood pressure changes. If there's a fall in blood pressure, the release of aldosterone from your adrenal glands will kick in. We know aldosterone will cause a reuptake of sodium, and where sodium goes, water follows. So that means we'll increase our volume. And we know from our blood pressure equation, if we increase our volume, we will increase our blood pressure. So whenever you have a fall in blood pressure, your endocrine system says, let's kick out some aldosterone from the adrenal glands, and that will occur. ADH from the pituitary gland will also be secreted, and ADH stands for anti-diuretic hormone. If you don't have diuresis, right, then you reuptake fluid. If you reuptake fluid, you're going to have an increase in your blood pressure due to an increase in volume. So that's how ADH and aldosterone respond with the endocrine system. So those releases will actually cause an additional peripheral vasoconstriction. ADH definitely causes some vasoconstriction. And it's actually vasopressin is the other name for ADH, so that's an easy way to remember. And the conservation of water in the kidneys will increase your overall volume, increasing blood pressure. The cardiovascular system falls to provide a sufficient circulation for the body, or if it fails to provide sufficient circulation for the body, the result is hypoperfusion or shock. Right? If the let me say that again. If the cardiovascular system fails to provide sufficient circulation for the body, the result is hypoperfusion or shock. So whenever your cardiovascular system isn't doing its job, you have a hypoperfused state. And the delivery of oxygen to keep the body's tissues from becoming ischemic depends on adequate heart rate, stroke volume, your hemoglobin levels. Hemoglobin, remember, again, that's what carries oxygen. So if you want to keep oxygen moving throughout the body, you have to have a good amount of hemoglobin. A decrease in hemoglobin we know is called anemia, right? And then your arterial oxygen saturation. So if you're not ventilating and oxygenating well, you can also have a shock state. So you have to make sure you're maintaining airway, breathing, and circulation. Those are our ABCs, right? And that brings us to the end of this first video on bleeding, the anatomy and physiology review. It was very basic, I know, but this is how it relates to bleeding and hypovolemic shock and all of that fun stuff.